All right. Good morning, everybody. I think I'm going to sit with you because I got to run slides. So thank you so much for this invitation. I do give a fair amount of, but I've never talked to a group of neurosurgeons, so that's intimidating. You guys are arguably the smartest and the most hardworking people in this place. So I don't know if there's anything I can tell you that is going to, entertain you at 7 o'clock in the morning. I will give it a try. All right. Okay. So I'm going to talk a little bit about this notion of how do we leverage psychiatry, or for that matter, any other super specialist. If we want to try to move the needle on improving health on a population basis. That's basically the sort of the big picture theme. Before I launch into that, a little bit of disclosure. I already did this, and thank you for that really, really nice introduction, my friend. My day job is I chair the psychiatry department here. I have some adjunct appointments in the School of Public Health. I do grant and contract funded research on the theme of, bringing psychiatry into the rest of healthcare, the rest of medicine. I don't think I have any other disclosures. I don't do any paid work for pharmaceutical or device manufacturers. A little bit about us as a department before I get into the rest of this. So we have a pretty big department here. There's about 1,350 of us, about 350 paid faculty, about 400 clinical courtesy faculty, about 300 staff, and about 250 trainees. So it's a big department. We're the only academic psychiatry department for this 5-state region up here in the Pacific Northwest. And so we practice in a lot of places. We practice in all of our hospitals here. We practice with our colleagues at Seattle Children's Hospital, at the VA, actually the VA hospital here in Seattle, and also the American Lake VA Hospital that's down by Tacoma. We have a residency program in Idaho. We have a residency program in Montana in partnership with the Billings Clinic. So we're kind of spread out. Maybe a little bit more. A couple more data points. We staff about 250 inpatient beds in our own academic healthcare system. We have a large residency program, about 100 residents in our program. We're now the largest psychiatry residency program in the US. Wow. Couple very brief slides just to kind of, hopefully not to offend anybody, but people will ask me, what's mental health? And I'm going to just do super simple mental health 101. And the point I'm trying to get across here, mental health isn't something you either have or you don't have. It's almost always on a complete spectrum. It's not black or white. That makes it sometimes a little hard to wrap your head around. So just to do an example, let's say we think about stress. How do we cope with stress? We all have stress from lots of different things, family, school, work, financial. And I put a little quote in here from a surgical education journal that says, and hopefully I'm not offending anybody, neurosurgeons demonstrate high rates of stress and higher rates of burnout symptoms than other surgical specialties. That's probably not you people, but there it is. And what do we need to try to cope with all that stress? So I think we need 3 things, right? We need a good brain. So the biology has to be intact. We need really strong coping mechanisms. So our psychology has to be functional, and we need really strong support systems. So, in psychiatry, we really think of what's called the biopsychosocial model. All 3 of these things have to click to make that work for us on a good day. And so as an example, I'm not going to do a neurosurgery example because I probably would offend too many people, and I don't really know what I'm talking about. So I'll give you an example from the COVID-19 pandemic. So when that thing came at us, nobody was really prepared for this. We all experienced at different times some degree of anxiety or worry, right? Is this thing gonna kill me? Is this thing gonna keep me from doing surgery? Is this thing what is it gonna do? Right? That's normal. So we have what's called an acute stress experience. Some of us had more than that. Some of us lost loved ones. Some of you lost the ability to operate. So you had loss, you had grief, you had all these things that are actually normal and adaptive. So most of us can handle a fair amount of stress And we're pretty flexible, we're pretty resilient. We tend to bend but not break. But some of us break. And so that's maybe a way to think about that's the difference. So there's a small group of people that we're seeing now in our clinics that broke. What does that mean? They have all of those same experiences that we did. They may have lost a loved one, maybe they lost a patient under a really difficult circumstance, and somehow they didn't really move past that. They are now racked with constant anxiety, worry. They're vigilant. They're constantly thinking, what's the next thing that's going to come and get me? They cannot get that out of their heads. They're avoiding the things that sort of make them think, what's going to be the next thing that gets my family in trouble. They're having flashbacks. They can't undo the very, very true memories. And they can be very real, very visual or auditory memories. They're having flashbacks. They can't let go. And if you have that kind of thing long enough, you start getting depressed. You start getting hopeless. You start doing things that are probably not so good for you. You start doing some pretty maladaptive coping things. Maybe you're self-medicating with alcohol or some other drugs. And eventually, some people are just throwing in the towel. And we see a pretty significant increase in suicide rates in a group like this. So what happened to that? That's what we call in our business post-traumatic stress disorder. You could also get that from a war trauma or any kind of trauma. But that's the difference between, so that's why I said it's on a spectrum. That's the difference between, having had a normal experience and navigating that and being a perfectly normal person, but after something like that, you could come back and you look like you're a broken person. That's maybe just a little bit of an example. And what do we need? I said we need healthy biology. I'm not going to do this slide because I'll really offend you. Because what do we need? We need a healthy brain, right? So we need that 3-pound organ in our head that we both love and share in some ways, that is mostly made out of water and a couple 100 billion cells. We need that to be functioning. And how do we keep that functioning? So again, very simplistic stuff, but it's interesting because people sort of map somewhere on this slide. So some of us are worrying about how can you help a person start out with the healthiest brain they could have? So we have in our department, for example, now a pretty big investment in something called perinatal mental health. So we are thinking about someone's brain before they're even born. Because if you spend 9 months in utero and you're exposed to a ton of stress hormones or a bunch of toxic substances, you're going to come out with a different hardware, with a different brain than you would have otherwise. And now you have, a kid that's maybe a very messy kid with a mother that might be really, really stressed out. And something that we have learned that needs to happen in the first year or two of life, which is a normal attachment, can't really happen. And now you have a kid that's going to be at very, very high risk for mental health and addiction problems down the road. So maybe we need to start way upstream and thinking about how can we have the healthiest brain possible. So we have 7 or 8 faculty who do nothing but think about, how do we have good perinatal mental health. Once we're out, we got to protect the brain. You all could tell me more about this than I can tell you. What do we do to protect it from trauma, from toxic substances? Later on, it's about preventing vascular disease, managing chronic stress. We have very good data now that people who have early life traumatic experience, abusive experience, they will run with high levels of cortisol persistently, and they'll have a different hippocampus and a completely different, response when it comes to emotional regulation than a person who doesn't have those kind of experience. Once we get a little bit further along, there are some things we can do, I think, to try to, in a sense, train and exercise your brain. And I think we have a whole lot of work now going on. What does that actually mean? Just like you want to exercise your body, what does it look like if you want to have a healthy brain in your 70s and 80s? What should we be doing with our brains? To keep them functioning as much as possible. And then, sometimes the brains are broken and then we have to think about between all of us, how do we fix that, right? So we use medications to help modulate some kind of brain activity. Our colleagues in our department, we have 100 psychologists in our department. They will use psychotherapy to help us, I think literally, rewire, train our brains. And I think those two things in combination can be very, very effective because the brain is a lot more plastic than we're all taught. in medical school 30 years ago. We have a whole range of treatments now that sort of fall in the category of brain stimulation or neuromodulation. And, somewhere we overlap there. We are doing things like ECT and transcranial magnetic stimulation. You got bold enough to go into the brain. And there's, I think, a whole bunch of room for interesting work in deep brain stimulation, that we have seen some starting in the 90s, in our field, but I bet we're going to see a lot more applications of that kind of thing in the next 10 or 15 years to come. And then I think there is going to be room for technology, even maybe AI to say, how do we help a person who has, a brain that's not 100% functioning or that broke in some aspect? How can we help compensate for that? I think we're going to see a lot of change and a lot of innovation in that area. So, but what if things go wrong with your brain? So, in our business, we think of common mental health problems. We see people with depression, with anxiety. We see people with really severe mental illnesses, people who have autism, who have schizophrenia, who have bipolar disorder, or at the end of life, people whose brains are degenerating because of dementia. And I put a bunch of pictures of people up here that you will recognize, people who were very public about the fact that they were struggling with a serious mental health addiction problem. And I think that's been a really good thing, because I think it helps normalize people, and it helps address the fact that a lot of people are still afraid to talk about these things. These things carry a lot more stigma than most everything else that we see in healthcare. And it requires us to say, I had this, I'm living with it, and I found somebody who could help me function with it, because that's what normalizes it. I'm thinking about, I'll just make a tiny little detour here. When I trained, I did my internship during the time of HIV when there was no enteroretrovirals yet. I worked on a inpatient unit, on a medicine unit, where every night I pronounced somebody that people were dying from AIDS. It was a horrible, horrible time. And everybody was afraid. AIDS was probably the most stigmatized thing we saw. And then, treatments came along, and now we have TV ads for people saying you can take a shot 6 times a year and live healthy with HIV, right? Now that stigma is mostly gone. It's not completely gone. But, effective treatment for something, I think, is the single most thing we can do to try to address stigma. But then people have to come out and say, I had this and I got care. And I'm a person who's walking down the hall, and I can function with this illness. So I think it can make a huge, huge difference. Just very briefly, what's the cost of all this mental health and addiction problems? It's the single largest cause of disability that we have in healthcare. In fact, our colleagues at our own Institute for Health Metrics and Evaluation will tell us that you look at health conditions that make it hard for you to do the things you want to do in your life in terms of health-related disability. Mental health and addiction problems drive 30% of all health-related disability, 5 times more than diabetes or heart disease, 15 times more than cancer. Now, you might say, how is this possible? Because cancer is a terrible thing. If I got it, it might kill me. And that's true. The big difference is the kind of stuff that we worry about, autism, schizophrenia, bipolar disorder, that's stuff that most of us present with very early in our lives. So they're not waiting until they're adults. They're showing up, at Seattle Children's. They're having early episodes of psychosis. They might have mood disorders. They might have bipolar disorder. And then if we don't treat that successfully, you spend the rest of your life impaired by this. That's where the big cumulative burden of these diseases come. Cancer is very different. Most of us, if we're going to have cancer, it'll come at us in the 70s and 80s. And then it's pretty bad. It could be pretty bad. I mean, if you get a brain cancer, you know what happens, right? But it might shave off the last 3 or 4 years of your life. So from a cumulative burden on human being, it's actually a lot smaller. So mental health problems are also a big driver of mortality. We have in the US now somebody dying from suicide or a drug overdose every 5 minutes. And these are not numbers that are going down, they're going up. A lot of people are racking their brains to think about what's behind that. This is a slide from our colleagues at IHME, where they try to quantify for all the people living in the state of Washington, what is the biggest drivers of disability. And I outlined here in red all the things that show up in our clinics: depression, anxiety, schizophrenia, bipolar disorder, and alcohol and substance use. A huge portion of all disability is really in this space. Now, what are we doing about this? So if you think about all the little people on this slide, those are all the people who live in any kind of community with a diagnosable mental health or addiction problem. Let's just say all the people in the United States, or all the people in the state of Washington today living with a diagnosable substance use problem or a mental health problem. How many of them will see a psychiatrist in the next 12 months? What do you think? Anybody want to? Can't get an appointment. Can't get an appointment, yeah. How many? 1%.
Zero.
Okay, 10%. Not that bad, but it's 1 out of 10. Now you might say, okay, we don't need a psychiatrist for all these people. There are a lot of people who are trained to help somebody with a mental health or addiction problem. What about psychologists? What about social workers? What about, we have a whole bunch of counselors. What about even pastoral counselors? If you take a really broad definition of anybody who's got any kind of training to help somebody with a mental health or addiction problem, and we'll say of all these people who live with a diagnosable illness, how many of them will see anybody for even one session in the next 12 months? It's 1 out of 5, 20%, right? Now, that's not so great. And I show this slide to my colleagues in our department because there's 350 of us and they think they're pretty good and they're pretty smart and they're doing a lot of hard work. But I'm like, you're helping 1 out of 10 people who need your help, right? This is not going to be a great solution. 40% of people, and this has changed a lot since I started in this business 30 years ago, will get some help for a mental health problem in primary care. And I see that as the glass is half full. I'm an optimist, so I think the glass is half full. The glass is still half empty because 60% of people will get zero contacts with anybody who's got anything. Now, I just told you a couple minutes ago that psychiatric illnesses cause 15 times more disability than cancer. What if this was cancer? What if I said that of all the people who are living in Seattle with cancer, 10% get to see an oncologist sometime in the next 12 months. 20% will get to see any kind of health professional, or 40%. 60% will get nothing. We find that totally unacceptable, right? But that's kind of where we are. That's not something I'm proud of, but that's the reality. That's what we're up against. Now, what are we doing in psychiatry about this? When you refer a patient to me, what I'm trained to do is what we call in our business the 50-minute hour. So you'll send me the patient. I'll spend about 50 minutes with them in my clinic. I'll see them, I'll meet them, I'll try to establish a relationship with them. I'll read all of their medical records. I'll do a really thorough interview. I'll try to figure out what's going on with this person. We try to come up with a working diagnosis. We make a treatment plan, and then I try to wrap up the session. And then I say, come back and see me in X amount of weeks. I want 10 minutes because I need to write a chart note. Maybe I need to go to the bathroom. I need to go to get a cup of coffee. And then I go to the next one. That's what we're trained to do. And our residents are complaining about that because they're saying, hey, I need 2 hours and get all this great history. I need more time than that. I can't do this in 50 minutes. And I have to tell them, if you can't do it in 50 minutes, you'll be poor. You better figure this out. So a couple of months ago, we did a really interesting little exercise in our research group. We said, if we make a conservative assumption that at any given time, 3% of the US population could benefit from having an hour with a psychiatrist once a month, that's actually a very conservative assumption. How many of these hours do we have to sell? So we took all 45,000 psychiatrists who are licensed to practice in the United States. And we said, if we divide the number of populations into that, and we say that psychiatrists do nothing but see patients 50 hours a week, all day, basically. How many of these hours do we have? So if you live in Seattle, if you live in an urban part of the United States, we have about 60 minutes for you every month. If you live in Eastern Washington or any part of the rural United States, we have about 1.5 minutes, right? If you lived somewhere in India, we'd have about 20 seconds for you. If you're living in most African countries, we have about 4 or 5 seconds a month for you. So this 50-minute hour is really cool, and we can do some really cool magical work for some of our patients, but it doesn't scale. So it's a big challenge that we have. And So there's lots of good data. We will never have enough psychiatrists in the state of Washington. About half of the counties in the state of Washington don't have not even just no psychiatrists, but no psychiatrists, no psychologists, no social worker, not a single person who's trained to help anybody with a mental health problem. So we have a huge workforce challenge. We also don't have enough inpatient beds, and I think there's a lot of reasons for that. As I said, this has traditionally been a highly stigmatized group of problems. People didn't want to talk about it. They didn't want to pretend that it existed. So people were housed in big, large state mental hospitals. We still have in this state the single largest old style state mental hospital, Western State Hospital. It's down south of Tacoma. There's over 1,000 patients there. It was built in the year 1871, and it still looks like it's 1871. It looks nothing like any of the modern healthcare facilities that we think about. Somebody who's got a seriously broken brain should be getting their care at. That's kind of where we're at, what we're up against. And the other thing we've seen over the last 100 years is we used to have a lot of people spending time in mental health hospitals. You see that light blue curve here. And where have most of them gone? Most people have closed all their mental hospital inpatient beds. And where are these people now? A lot of them are in jails and in prisons because eventually that broken brain gets them in enough trouble where they get in trouble and they end up getting arrested and they end up. So our prisons and our jails are actually the single largest mental health hospitals. The LA jail is the largest single mental health institution in the United States. And you might imagine that's not a great place to take care of somebody who's struggling with a serious mental health problem. So all I've done here for the first 20 some minutes is tell you about a whole host of problems. And I'm going to try to shift gears a little bit and talk a little bit about what are we going to do about this? What can we do to close these gaps? And I think, some of these strategies are good in psychiatry, but I think a lot of them actually are pretty good in other parts of healthcare. So we do need to train and retain more people working in this field. And that's why we have in our department here, the single largest psychiatry residency program in the United States now. We also need to think about how do we work smarter? Are there ways that we can use technology to try to leverage what I can do with my 50-minute hour? We need to collaborate. We need to think about who else can help us take care of these people. So I'll give some examples about working with primary care, working with schools. And I do think we need to work further upstream. So that's why we're shifting to saying, what can we do very early on in life so that problems don't fester and don't develop? So that's why we invested in this notion of perinatal mental health. I'll give a couple examples of each of these. So the first thing is, I sort of realized 30 some years ago when I came here as a fellow, most patients don't ever come and see a psychiatrist, but they're seeing our colleagues in primary care. And I start talking to them and they start saying, we got these patients all over our clinics. And I said, what could I do as a psychiatrist to help you when you have a patient who is seriously depressed, who is anxious, who is struggling with alcoholism? What can I do to help train you, to help prepare you? And they said, I need more than training. I need somebody here who knows what they're doing. So we tested this model called collaborative care, where we have a primary care physician and a patient, and we train somebody in their office. That could be a nurse, that could be a social worker, could be a psychologist, and we say, you're going to practice alongside this physician, and you're going to take care of all the patients in this physician's panel who's struggling with a mental health or addiction problem. And we're going to train you in doing some pretty straightforward things. They're brief psychotherapy treatments that are highly effective in addition to a medication that physician might prescribe. We track all of those patients in a population registry tool, and we have a psychiatrist who gets attached to each of these teams who doesn't do all the care, who doesn't give a lot of 50-minute hours, but that psychiatrist once a week runs a list of every single patient who is in this panel who's struggling with depression or anxiety or a substance use problem, and looks at them and says, we might be missing something on the diagnosis, or we might be using the wrong treatment. Here's some suggestions for how to change things. So it's really practicing as a consultant, in a highly organized way. We tested this about 20 years ago. We did a very, very large study in 8 healthcare organizations in 5 states, where we took 2,000 patients in primary care who had serious mental health or addiction problems, severe depression, for example, and we said, what's the likelihood that that problem is going to be significantly improved 12 months later? That's our primary outcome here. This is from a paper in JAMA. In eight healthcare organizations, we took 200 people and we randomly assigned them. 100 of them got what we call usual care. Usual care is just that. We said to the doctor, your patient has depression, they have anxiety, do anything you can over the next 12 months to treat them. So these doctors, what do? They all prescribe medications. Every one of these doctors wrote prescription for an antidepressant medication or some other kind of medication. About 20% of them said, that's too complicated, I'm referring to mental health. So that's usual care. The orange bars, that's our blue bars here on this slide. The orange bars, we offered them in the practice, a care manager who was trained to do brief psychotherapy, who helped us track the patient, a psychiatric consultant who could review all these patients once a week and make recommendations. And a year later, we saw that we could roughly double the likelihood that that mental health problem is significantly improved. And that worked in every single one of the places where we tried it. So same doctors, same patients, just a different way of organizing care. We also found out that if you do this, it turns out to be pretty cost effective. So we found out that for every dollar we spent on this intervention, we saw $6.50 in reductions in total healthcare spending 4 years later, over the next 4 years. That got picked up in the Wall Street Journal, and the Wall Street Journal wrote a little article about this, and that got me more attention than anything I've ever published in the New England Journal of Medicine. So, or the JAMA. So my advice for you, if you want to get early career attention, get somebody at the Wall Street Journal to write about your work. People seem to more likely to care about that. We took this notion, this worked very, very well. We took this notion and we said, what if we combine it with this idea of going upstream? So we did a really nice project with Seattle Public Health, Seattle King County Public Health, where we worked with 12 clinics that are taking, 14 clinics actually, that are taking care of a group of high-risk moms with severe depression in their clinics. And we said, what if we put this kind of collaborative care into these clinics and we treated moms who are, seriously depressed. About 34% of them had active thoughts of suicide at the time that we put them into this project. And we helped them with their depression using this kind of collaborative care approach. And there we did not do a randomized controlled trial. We did a before and after study. And so we followed a group of mothers before we implemented this intervention. And what I'm showing you here is what's called a survival analysis. So I'm showing you the number of weeks that go by until a certain proportion of people no longer are severely depressed. And so the blue curve is the before. So it took about 64 weeks, over a year on average, until 50% of the moms treated in these clinics were no longer severely depressed. Once we implemented this collaborative care approach, we shifted this curve way over to the left. So now we're talking about 8 or 10 weeks until somebody is no longer severely depressed. That's a huge difference. If you're pregnant, if you're trying to parent. So you can make a big difference with something like this. The Mayo Clinic picked this up. They were not involved in any of the original research. They said, we are so good. I'm sure our doctors are so good that we wouldn't have these kinds of problems. So they looked and realized that most of the patients that were treated in Mayo primary care clinics, it also took a long time for them to get improvement in their depression. In fact, they looked at their usual care and they said it's about 600 days until we can document the average person who is in treatment for depression, who was started on an antidepressant, is significantly improved. They implemented their version of this kind of collaborative care program, and it shortened that to 86 days. They published this on their own. We did all this research and we said, that's really exciting. It seems to work. It got us publications. It got some of us promoted. But then I said, look, we're not really doing this in our own healthcare system. So over the last 15 years or so, we've actually rolled this kind of approach, this kind of collaborative care approach out to virtually all of the UW Medicine affiliated primary care clinics. We now have a primary care team, a collaborative care team at each of these 20 clinics. And I think we've learned a lot. Doing it in the real world is a little different than doing it in research, because in research, you get a big grant, you have someone else's money, and people will pretty much do anything you want them to do. When you go into a healthcare system and say, you got to play this game, it's a different game, I don't have any money for you, just do it. It gets a lot more challenging. But we actually have learned that you can actually still get pretty darn good outcomes. We did a partnership with a managed Medicaid company here in the state of Washington that serves low-income clients, Medicaid clients all over the state of Washington. And we train people in over 100 clinics to do this kind of collaborative care. And I sold 4 FTE of psychiatry time out of our department to provide that kind of consultation to every one of these clinics. So a lot of our psychiatrists will have one afternoon a week where they're a collaborative care consultant to one of these clinics. And we managed over 50,000 clients, in this approach, and we got fabulous clinical outcomes. We are still doing that. So you can actually take that kind of thing and scale it pretty effectively. We built a program called the AIM Center that teaches organizations how to implement this kind of thing. We wrote a little book about how do you do this kind of work. It's different practice from the 50-minute hour. So a psychiatrist hasn't really learned how to do this in their residency. They're learning the 50-minute hour. This is very different kind of work. You don't get to see all the patients. You have to figure out how to work with a team. How do I trust that person on the other end who's telling me this is what's going on or that's what's going on? When do I hear a story where I have to say, look, I don't know, I'm not sure this is depression. The next time you have that patient in, I need to see them. And we do that using telehealth. So I don't need a 50-minute hour to figure out if one of you has bipolar disorder. If I have enough history, I need 15 minutes of asking you the right questions. And I can figure out, okay, this is not really unipolar depression, this is bipolar depression. And then we can go on and change the treatment, right? So you can use that time in a very different kind of way. We have funding from the state to provide this kind of training and some ongoing support. We do an ECHO-style case conference for primary care providers throughout the state, where we discuss challenging cases that are coming up in these reviews, done thousands of them. And over the last 6 years, we've trained providers in virtually every county, I think all but one county in the Southeast, and how to do this work. And I think it's been the most satisfying thing that I've ever done, because I don't get to see all the patients, but I get to see the numbers, and I get to see that we can help a lot of patients in a lot of places who, well, they can't all come here. I don't have enough people, for me to see them here. We had a grant from Medicare to train 3,500 psychiatrists around the country on how to do this, because we work with Medicare to develop a billing code. Our primary care practices can bill for this kind of care, because without a billing code, you can have the best research intervention in the world, but if somebody can't make money selling it, they're not going to do it. So it's been interesting. It's taken us 10 or 15 years to do the research, 10 or 15 years to get people to start using it. And then we realized we don't have a good billing code for this. So it took us 10 years to work with Medicare to get billing codes for this kind of collaborative care work. And so it's a real 30-year journey if you want to really make a significant impact on something like this. Switching gears just for a couple minutes here. A couple years ago, I got to talking with our governor, Jay Inslee. Jay was running, I think, for the 3rd term as a governor. He had done a listening tour around the state, and he got an earful from people about the fact that we have all these undiagnosed mental health problems. We have no help. Most of these counties don't have anybody who can help. We have an opioid epidemic. And he came and talked to me and said, what do we got? I said, we got a state hospital that was built in the year 1871. It's a terrible place. Everybody's afraid to go there. We don't have much else. We need to do something different. So Jay came out right before he ran for the 3rd time and unveiled a very ambitious $675 million plan to invest Washington state tax resources to try to strengthen our mental health system. And there are a couple of things that we partnered with them on in a strategic way. The first one is, I said, you need people. You need more workforce. So give us some money to fund our psychiatry training program, because we basically have no money to train psychiatrists, and psychiatry is not a giant revenue producer. So I said, you need to give us some state resources so we can grow our psychiatry program. So we grew our psychiatry training program, we grew our child psychiatry fellowship. And the other thing we said is, you need something better than something that was built in the year 1871. I said, if you give us $250 million, we'll build you a state-of-the-art, brand new Center for Behavioral Health and Learning that can take care of some of the sickest people with mental health problems in the state of Washington. And it can also help train the next generation of people, because right now, if I have to take a resident and send them down to the state hospital and let them practice there, or if I send a medical student down there, they're going to come back and say, that's the last thing I'll ever do. You know, that thing looks like, you know, if one flew over the cuckoo's nest, it's terrible. I saw horrible things there. Nobody gets better. You know, why the heck would I choose psychiatry as a profession? I said, no wonder nobody wants to train in this field. You know, we need to show them, you know, state-of-the-art care in a really nice facility. He said, all right. And then he said, well, what can you do right now for me? And he said to me, you know, I talk to these people in Ferry County, which is way over on the east side of the state, very rural part of the state. And he said, you know, they got somebody in their office or in the emergency room, you know, they're talking like they're God, they're crazy, you know, they don't know what to do. What can you do to help me with that? He said, what about this? He said, what if you had a thing where anybody anywhere in the state could just pick up the phone anytime, 24/7, and just call a psychiatrist in your department and get some advice. And I thought about it for a minute. I thought, that's insane. I could never do that. My faculty will kill me if I say I signed you up for this. But I said, okay, let's do it. So we developed a consultation service, and we operate that for 365 days a year, 24/7. Anybody anywhere in the state who's got a patient in their office who's got mental health or addiction problems can pick up the phone and talk to a psychiatrist. Sounded a little bit insane, but we actually have it. I'll say a little bit more about that in just a minute. So the first thing we did is we got this wonderful opportunity to work with the state of Washington to build a $250 million brand new facility. It's up on the Northwest campus. It just opened up earlier this year. It's attached to the main hospital. It's got 150 beds in it, and 75 people who have very severe, complicated mental health and addiction problem. 50 of these beds are medical surgical beds for people who have psychiatric needs, because people who have psychiatric needs also have medical surgical needs, and we forget them. So that state hospital is not a good place for you to get treatment for an infected heart valve or for your diabetes that's under control, that's out of control. So we built 50 beds that are med-surg beds, but that are really capable of taking care of people who have both mental health and addiction problems also. This is a little bit what it looks like. It's a beautiful building. I'm a little biased on it. It's got a lot of daylight. It's got fresh air. We have places for people to go outside in a safe way, which is unusual for facilities like this. The other thing we have is this consultation line. And like I said, you could be anywhere. You could even be in your own clinic here. If you call this number, you get to talk to a psychiatrist. One of the people, there's 30 of us. We're taking rotations. Some of us are on call at night. Some of us are on call during the day. And we'll take a call from you, and you'll tell us about what's going on with your patient. And we won't say, send me the patient, I'll take care of them, but we'll talk you through what to do. So I'll give you an example. I was on call a couple of weeks ago on a Saturday evening, and I get a call from an obstetrician in a small rural county in the state. And he's telling me about the fact that he's got a 17-year-old young lady in the emergency room. She's second trimester pregnant. She's got type 1 diabetes. She's made a suicide attempt because she had a huge argument, with her family. And she's been using her insulin to kind of manipulate, her blood sugar and everything else around her life. And it's complete chaos. What does he do with this? So I'm like, okay, that's not a question. There's a lot of challenges here, a lot of questions. But I said, look, I'm a general psychiatrist. I'll talk you through what I think you could do right now. I'll talk you through what I think you should do. Probably shouldn't be using lithium for this person because the kid's going to be high risk for having a cardiac malformation, and so on. So there are some things we worked through, but I said, this is a sort of unique situation. So I said, I got a couple people in my department who are perinatal mental health specialists. That's what they do. They deal with people who are pregnant, in a high-risk situation like this. I'll get one of them on the phone. I'll call one of my colleagues, had a wonderful three-way conversation about what to do with this patient. I learned a ton. That guy learned a ton. He was super grateful. And the nice thing about that is not only were we able to do something right there for this person, that person learned a lot. And that's been my experience when we do these consultations. It's a great way to teach. We all like to teach. We're here at a university. So every one of these calls, and we do thousands of them now, is an opportunity to teach somebody. And we work with doctors who are really smart. When I say to them, don't do this, try to do that, they're not just doing that for this patient that time, they're doing that with their next 5 or 6 patients. And I think we have a really nice opportunity to bring up the skill level. The way I see that in my practice is I've been doing one of these consultations with a clinic going 10 years. And when I first started that, I was a really smart guy. They would call me and say, I got this person, I put them on a little Prozac, they're not getting much better. And I'd say, double the dose. And, a couple of weeks later, I'd say, how are you doing with that patient? They'd say, they're doing a lot better. I'm like, great, I'm a really smart guy. And the guy thought I was really smart. Now that guy is calling me with the kind of patient that I just mentioned to you. I'm not so smart anymore because this is now really challenging. Why is he doing that? Because he's learned all that stuff. So I think you can bring the skill level of, of people up quite a bit when you do that kind of real-time consultation. The last couple of minutes I'm going to spend on another thing that we're doing, which I think is really exciting because while we have some pretty good treatments for many of the patients we take care of, we need a lot more solutions, a lot more treatments. And a couple of years ago, we had this wonderful gift. We got a $50 million foundation gift. Rich and a couple of colleagues helped us vision this at a retreat, maybe almost 10 years ago, 7, 8 years ago, from a guy and a lady named Mike and Lynn Garvey, who are in our community here, who gave us a $50 million gift to something called the Garvey Institute for Brain Health Solutions. And I'll tell you just a little bit about that. First of all, I thought this was a home run because what I had known over the 30 years that I worked in this field and what is true is when it comes to philanthropy, when it comes to charitable, people do not spend money on mental health. This is a slide from The Economist where they show how much dollars in philanthropy for mental health compared to heart disease and cancer. So we thought it was really nice that we had made that kind of thing. So what are we doing with this money? The first thing we did is we need to train more physicians. So we partnered with our colleagues in the Department of Neurology. We built a fellowship program that is training physicians really thinking about brain health from both a neurological and a psychiatric perspective. So we have a new fellowship that psychiatrists and neurologists can do. That is for the neurologists, it's called behavioral neurology. For us, it's called neuropsychiatry. We have neurologists and a psychiatrist program director, and we've just recruited our first cohort of fellows, 1 neurologist, 1 psychiatrist, and they're working together to think about how do we work differently if we try to bridge what we know across these 2 fields. We just recruited our second cohort of fellows, and I think that's a really neat thing to see where that will go. We have a couple of themes that we're focusing on. One of them is on cognitive aging and brain wellness. And the idea there is, what do we really know? Okay, sorry about that. What do we really know about preventing dementia, right? There is a nice Lancet article out just a couple months ago that said 45% of all cases of dementia actually could be prevented if we did all the right things that we already know. So how do we do that? How do we put that in place? How do we scale that? So that's one of the things we're tackling in this project. The second challenge we're taking on is addiction. Addiction is a huge challenge for us nationally. 500,000 people who are still dying every year from smoking. There's 200,000 people who are dying related to alcohol every year. And we have 100,000 people who are dying from drug overdoses. So a huge challenge for us. And we need, I think, solutions that are different, that are really new. So we're investing all the way from very basic neuroscience, understanding what's happening in a brain that's more likely to struggle with an addiction than another brain. What's resilience like? How do people recover from addiction? What does that look like in the brain? And then we're doing some things that I think are a little out there, but I think have a lot of promise. So we have a new center that's developing vaccines for people to protect them from opioid use disorder. We have a new center that's trying novel therapeutics. There's a whole bunch of interest now in could you use psychedelic substances to help somebody recover from an addiction? And so we've launched a couple of research programs that really focus on this. The picture on the bottom right is Marco Pravatoni. Marco is a really interesting guy. He's a pharmacologist at Harborview who has developed a handful of vaccines that prevent a mouse from wanting to use opioids. The question now is, will that work for humans? And then if that works, that's a dramatically different approach, from all of the ways that we're trying to go after people who are struggling with addictions right now. So we're just starting phase 1 trials. So the jury is still out how well that will work for humans, but I think it's an interesting strategy. The last area, we've invested a fair amount of money in saying, are there ways that we could use technology to improve mental health? In that new hospital that I talked about, we built a beautiful new Center for Neuromodulation. Right now, what we're offering there is things like ECT, electroconvulsive therapy, and transcranial magnetic stimulation for people who have major depression, who have serious anxiety, obsessive compulsive disorder, who have bipolar disorder, who have schizophrenia and catatonia. But I think we have a ton of opportunity there to try to work together to say, are there other things we could do to modulate people's brain circuits? So there's stuff that we will do that doesn't require tunneling into the brain, but there's stuff that you guys can do that does involve, deep brain stimulation, maybe some closed loop modalities where we could say, can we go after other mental health problems? Can we go after addiction? Can we go after people who are experiencing chronic pain that are not responding to other treatments? So I think we have a lot of opportunity there over the next 2 years to say, could we work together to try to really innovate in treatment? The last thing we're doing in the Institute is we have given 100 innovation grants. These are grants that are about $100,000 a piece to groups from all over the university. We've given these grants to people in all 3 UW campuses, 10 schools, 25 departments, including some in neurosurgery, for teams who are coming and saying, I got a really innovative new idea for trying to run at one of these problems. They tend to be a little bit more risky than what the NIH would normally fund, but I think it's really kind of fascinating. That's all relatively brand new still. I would say the jury is out how well these things will do. Some of them have already been super successful and gotten a whole bunch of other funding. So that $100,000 is just, make that you can do something, and then you could go to NIH for a lot larger grants. A whole bunch of really neat people, mostly young clinician scientists that we've been able to support through this initiative. And I think that's where I want to stop. So thank you. I know this was a super brief tour. It's not neurosurgery. Hopefully there were some interesting ideas. Happy to take any questions.
Yeah, the trouble with being brain people is that everybody who's not a brain person, who's completely comfortable with the kidneys and heart and want to shy away from the brain. They're sort of afraid of it, and they're not comfortable with any part of it. They don't do a good exam or good treatment because they're really not comfortable with it. And the diagnosis, which you're working with the primary care people, and the treatment, which you're also working with, is not a simple thing. Right. So these are people who are kind of afraid of the disease and don't know what to do on either end. Their exam may be dodgy, and their treatment they need help with. And so my question is, how do you deal with making people more comfortable keeping these people rather than they want to send them? And second, are there algorithmic approaches to giving people sort of a pocket card that help them with 80% of the diagnosis and then downstream the care?
Yeah, so I'll go with the last one first. So there are, it's like we say in medicine, the common stuff is common. And there's pretty obvious things that if you get all the right things, it's like teaching a pilot how to fly. There's this thing about should you have a checklist, and even a very experienced pilot still benefits from a checklist. So we have checklists for common things. Like what do you do with somebody who's got a drinking problem? What do you do with somebody who's got anxiety? What do you do with somebody who's got depression? If you miss 2 or 3 of these steps because of whatever biases you have or whatever you didn't do in your exam, it's probably not going to go well. The other thing we see is a lot of people, 25 million people, walk out of a primary care doctor's office every year with a prescription, usually for an antidepressant medication. But 1 out of 5 will get better. And so what we learned in that big study that we did is sometimes they got the diagnosis wrong. So we got to take a step back and say, hey, you missed something. That's not depression. That's something else, right? Sometimes it's the right treatment, but they got the dose wrong. So what they often do is they will start a treatment. the patient will take a little bit of an antidepressant and they're not much better. And they're like, oh, I guess that's as good as it's going to get. And what we said is, well, if you're going to do it, push the dose up. If it's not better yet, push it up again. If it's not better yet, after 6 weeks, that person is not going to get better. Try another drug. There's 30 of these antidepressants, right? It's not just one. And so if you just do that kind of thing, and it's pretty simple, it's not rocket science stuff, you can actually double or triple the likelihood that that person actually is going to get, eventually going to get the right diagnosis. The one thing as specialists, we tend to think we need to get the perfect thing the first time in. The one thing I learned from working in primary care is they don't need to get it right the first time in. They need to get it close to right. As long as they're open to saying, if it's not better yet, I'm willing to revisit the diagnosis or to revisit the treatment, you can iterate on this and you can actually get a lot closer to getting the right outcome that you want. My psychiatrists are saying, I can't do this. I need 50 minutes. I need maybe 2 hours. I need all this other data to get it right. And it's interesting because what I learned is, so I'd see a patient and I'd get all the history, and then I'd see them the second time, the third time, things aren't getting much better. And the fourth time, the person is comfortable enough to say, and by the way, let me tell you about that cocaine problem that I have that I didn't mention the first time I met you. I'm like, okay, that changes everything. But sometimes patients aren't really comfortable telling you the first time in all of the data. So what I've learned is, if you just stay on it and you're systematic about it and you iterate on it, you can actually get a lot closer to what might really be a challenge. So that's the answer, the long-winded answer to the algorithm question. I forgot the first one. Oh, people want to send the patient away. Yeah, so the good news or the bad news on that is there's nobody to send anybody to. As you said, you can't get an appointment. It's if you poll primary care doctors in the United States, and it's been done, about having access to specialty care, they will not complain about having access to neurosurgery. They do not complain about having access to orthopedics. They say, if I have a patient who's got serious mental health problems, I got nothing. I can't get them to seen by anybody. And I'm not proud of that. I'm not saying that's a good thing, but it is what it is. So when we go in and say, we already have these patients, we can help you co-manage these patients. As long as it's real, as long as it's a real offer, as long as we actually have their back, and as long as I say, you can call me on a Saturday evening, if that person is up in your office and said they want to hurt themselves, as long as I'm there, as long as it's a serious offer of backing them up, actually, people are very comfortable continuing to see those patients in their office. So that's one answer to that. I don't know if that works. All right.
Thank you so much for the presentation. I'm sitting here listening, going, gosh, thinking forward. I remember it's funny, LA County Public Health, there used to be a sign that says, prevention is caring, curing is costly. Everything you've described is reactionary. Neurology has also taken this consideration of, should there be preventative neurology? Thinking forward, are there considerations of preventative psychiatry, not saying the pregnant person when they're depressed, but ingraining the coping skills and strategies in advance so they don't even get depressed. And for every depressed diagnosis, and you know this better than any of us, there's 20 people who hit that borderline or crisis mode and just never tip to diagnosis. So it's the, take the millions of people problem and put it on the billion scale. Are there thoughts, maybe these would be global initiatives, but you do global, of how to systematize almost in a training and education model. It's almost like growth and development curves, that you would use, but from the standpoint of learning those coping strategies.
Yeah. So how far upstream can you go and can you prevent? I mean, like, you guys do this all the time. There's nobody's playing football anymore without a helmet on, right? That's prevention, right? So what's the mental health equivalent of wearing a helmet when you're going through life, right? People who are working on this, and there is people on a global scale who are really thinking about this, working on this. And it goes back to my very first super simplistic slide. Some of it is going to be brain biology focused. Some of it is going to be psychology focused, learning the right coping skills at the right time in your life. And some of them is going to be social, right? What kind of social supports, or how can I take away social stressors? So the right family leave policy might be a lot more important than a whole bunch of antidepressant medications when that person is totally overloaded and stressed out, right? So I think you could take those strategies and look at them from all three of these perspectives. We, for example, there's pretty good data that if you, so social, emotional, self-regulation skills are something we can teach. And you can teach that, with little kids, you can teach it in school. And there's a whole bunch of programs that actually do that, and that will make the case that that's a lot more cost effective from a population health perspective to do that with kids in school than to wait until somebody is, in an ER having cut on themselves because they can't find another way to communicate that they're really stressed out, right? So yes, absolutely. Lots of room for something like that.
Jürgen, I'm going to ask a practical neurosurgical question. We take care of people that we see them in the worst time of their life. They got a brain tumor, that bleed in their head.
Yeah.
How do we access, what is the best way for us to access our nurse practitioners and PAs deal with this all the time? I'm a brain tumor, I'm depressed. How do we access mental health help for biological disease or neurosurgical disease where it's affecting both the structure and then the effective reaction to it?
Yeah, it's a fair question. And I wish I could say just send them our way, but we have a wait list, and I'm not proud of this, in our outpatient clinic of about 1,000 patients. Part of the problem is the way we pay for care. When I put a faculty member in our clinic to do one of these 50-minute hours, they'll work really hard with a really sick patient who might be suicidal, who they're going to be thinking about later that day when they're at home. And they'll get $64 from Medicare for doing that. I can't pay their salary for that. So what am I trying to say here? It doesn't pay enough for us to do a lot of this care. So we are under-resourced. If we were making the kind of money that you guys can make, when you work with somebody for 50 minutes, we could be having the resources to make a huge difference. That's not helping you with your question. I'm just giving you a little defense.
I'm just thinking out loud. Maybe training, really the people that do hard work.
Yeah.
APPs.
Yeah.
And they're very good at everything. Can you train APPs?
Yeah.
On that?
Well, we can do a couple things. We could train people, and as I said, we have trained people on. You don't need to know everything. You need to know the common stuff, right? And we can do that. We do have at every one of our hospitals a consult service. In our primary care clinics, we do have our BHIP program. We really don't mind getting calls from people. Anybody here, even within our healthcare system, can call our 800 number. You will get to talk to a psychiatrist who, if they don't have the right answer for you, they will find somebody. We got a big department, and we have expertise in pretty much everything. Now you're busy, you're in clinic, you're like, I don't have 10, 15 minutes to talk to somebody. So sometimes that's challenging, but that could be helpful. And we are starting to get calls from within our own healthcare system.
Well, I'll get the 800 number, but I also think training our folks, who are on the front line and know the patients best may be helpful. So I'm going to follow up on that.
Yeah, so we have trained a lot of, like I said, we've trained primary care doctors, we've trained other kind of specialists.
We may not be as smart as primary care doctors.
No, you people are very, very smart. Go ahead.
I really appreciate your presentation and the overwhelming underlying theme here is scaling.
Yeah.
One word that didn't show up in your presentation, which I thought was interesting, is wellness. So wellness is, this wastebasket term for a lot of things, but is there value in scaling mental health, prevention, treatment, addressing it, diagnosis with this idea of wellness? Our residents get a wellness day. Our faculty are constantly being evaluated on it's done our surveys, right? Like, do you feel like you have wellness incorporated into your practice or whatever? Where does that fit in this world of psychiatry? And is it hocus pocus, or is it money making? To be facetious, is it just sort of is it just people who want to make money on apps and things like that, or is there actually something there?
Wow. Okay, I think it's a great question. I guess I think of it in two ways. One of them is I think of it in the question you just brought up. How much could we prevent, right? Are there things we could do for young people? Are there things we could do for a person who's starting in a profession? It's a scary experience to be an intern, right? Is there something we could do going into that prepares a person, to be a little bit less, a little bit more able to cope with all of that stress that comes at us. So that's kind of on the prevention side. I do have to say, people sometimes confuse, that's why I said the thing about the spectrum. So we don't get to see people who are not well. There's a whole bunch of people out there who are coaches, who are counselors of a whole bunch of varieties that'll see people who I don't think have a mental illness, but they could be more well. And there's a whole industry and a whole bunch of people who will pitch you something. I don't know how well it works. Some of it works, some of it may not work. That's sort of really more, I see that more on the spectrum of, could I have a coach that makes me live my life a little bit better? That's pretty far down from the spectrum. The people we see in our clinic are, there's no doubt that they're not well. They're worse than not well. They have either a broken brain or they have learned sort of psychological coping mechanisms that are so dysfunctional that they're getting them into huge amounts of trouble. I'm not saying that I wouldn't love to kind of get involved on the wellness part, but for the most part, what we see is well beyond wellness. The only other thing I will say is, and I smiled, and you probably can relate to this. I think the way we're trying to do wellness in medicine right now is kind of overwhelming. I mean, it affects my wellness when I get like 4 times a week something saying, are you doing enough wellness? I'm like, I need time. It's like exhausting, all this wellness stuff. It's like killing me. So I think we have to figure out, what of it is real? How much of it can we really sort of, what do we do with this? I think it's kind of cool right now and everybody's talking about it, but I think it can be, I don't know. I think you know what I'm trying to say.
Yeah. David, last question.
Okay, that was fabulous, really, really wonderful. So thank you. So, we're well on our way to becoming a minority majority culture. And many things about mental health differ by race, ethnicity, culture, geography. So, symptoms differ, manifestations differ, response to antidepressants differ, access to care differ, social determinants of health. You mentioned your slide, housing, all these other things differ. And so, as you think about population health, how do you think about sort of the next steps in adapting some of the things you're doing to our changing society?
Yeah, it's a really good question. So I could argue that both ways, and it's based on my experience and some data. So when we started the big trial that I just showed you, for example, we mostly did this in Texas and California. We had a very large population of Latinos, mostly Mexican Americans. We have a very big population of African Americans in this sample, mostly in Texas. And one of the things we looked at in this data set is the difference between our usual care patients and our intervention patients. This was not an intervention that was tailored in any meaningful way. We had significantly greater improvements in our minority populations relative to the usual care than we saw in our whites. Why is that? It's not because it was such culturally tailored care. It was because it was care. And the usual care for those populations is so awful that if you just give them decent standard care, it already made a huge difference. Now, that's not to say we shouldn't be thinking about what makes that even more culturally meaningful to them, what it would take for us to have them engage. But it was sort of striking. It was not what we expected, that we actually saw the relative benefit of doing this kind of an intervention was much greater and we've seen this in a couple of other studies now, in minority populations who are so disadvantaged from the get-go. The other thing we learned, which was interesting, sometimes that kind of tailoring is really tricky. So we looked at, for example, we had 2,000 patients and we looked at what is the pairing. So if your primary care physician is a man or a woman, if you're a patient who is a man or a woman, does it make a difference what the outcomes are? Now, that's a silly question, but we very basically so it turns out if you're an older man with depression who's treated by an older male physician, you were the least likely to get good care and to have good outcomes. Mm-hmm. And we actually interviewed a bunch of, if you were treated by a young female internist who just graduated from school, you might have a better outcome. We thought that's really weird. That's a complete mismatch. But it turns out we did qualitative interviews with these older physicians and they said, well, he's a very proud person, he's not comfortable talking about this kind of thing. If I bring up depression, he might be, he might be, I don't know, he'd be very uncomfortable and I'd make him very unhappy. He might even think about killing himself. I'm like, wait, he's already in your office. Already got depression. But it's very interesting because you can share facilitators because you share a culture, but you can also share barriers. So it's a very interesting and a very complex sort of dance to think about what does it take to get people, you know, culturally appropriate healthcare that they'll engage in, that they'll actually benefit from. And we could spend a lot of time on this. We have thought a lot about it, but it's a really interesting question.
This was amazing. Thank you very much. Thanks for that.
Thank you.